Ahiti, are you there?
Yes, ma'am. I'm starting the session.
Yeah.
Good evening, everyone. Hi. Happy Independence Day to all.
Thank you, Aruna.
Hi, Aruna.
Hi.
Thank you. Thank you and wish you the same, ma'am.
Thank you.
Good evening, dignitaries
Yeah.
and all the delegates. Thank you. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar on Women's Reproductive and Sexual Health Series 5, organized by the Obstetric and Gynecology Society of Southern India. So let me introduce the MOC of today's webinar, Dr. A. Vanitha. Ma'am is currently the director of Sunrays Laparoscopic Center, Chennai, and also the teaching faculty of EISC Chennai and managing committee member of OXY from 2021 to 2023. I welcome you, ma'am, and I hand over the session to you for further proceedings.
Thank you, Sahiti. A very good evening. Shubh Sandhya to all of you. On behalf of OXY 2023, I take great privilege in welcoming all the faculties, the delegates, the guest of honor for the day, Charulata ma'am, and our own OXY president, Jairani ma'am. A very happy Independence Day to all of you. मैं आप सभी के स्वागत करता हूँ आज इंडिपेंडेंस डे के वजह से. We welcome you all to this fifth series We welcome you all to the fifth series of women's reproductive and sexual health. It's always been a tradition to have a best beginning to every program, and the best way in Tamil Nadu to have it is with our own state anthem, which is the Tamil Thai Varthu. May I request you to all join us to invoke Lord Mother Tamil. Thank you. A ray of light is always a ray of hope. As a symbolic representation of dispelling the darkness of ignorance, now we will have the virtual lamp lighting ceremony. May I request all our faculties and the dignitaries and the delegates to join us for the virtual lamp lighting. Thank you. In all our academic events, we always take privilege in doing our OXY prayer before we start the session. And I take the absolute privilege of doing it today. Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given to us. Shower us with your blessings to pass on the healing touch and to celebrate the arrival of each new life and a mom reborn. The courage to deal with it all when things are not perfect and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you. To formally welcome the gathering and the dignitaries, may I request our OXY President, Dr. Jairani Madam, to come over. She is the Senior Consultant of Reproductive Medicine and Director of Akash Fertility Center, Chennai. She's the Treasurer of Tapisar. She's Associate Secretary of World Association of Sexual Health, Advisory Council member, World Association of Sexual Health. And ma'am has innumerable awards and medals. And, she's a member of many associations, and she's conducted several conferences. And if I have to put it in nutshell, Jairani madam is a symbol of energy, always ever willing, ever jubilant person, always, very forthcoming to whatever ideas we give her, and always ready to implement everything that comes out of the committee. I welcome you, ma'am, to formally welcome the gathering.
Thank you, Vanita. Thank you for the nice introduction. It gives me a great pleasure, honor, and I wish you all a very happy Independence Day. We all women stand for to say in unity the independence what we got on this day, which would be definitely a symbol of independence for all the women force here. And I wish you all a very happy Independence Day. And I have the great pleasure and honor to welcome you one and all for this Women's Reproductive and Sexual Health Series 5, which we conduct every month on the third Tuesday between 7 and 9 p.m. by our Society, Obstetric Society of South India, Chennai, by which we include many of the national national societies. This time we have included many faculties from Madhya Pradesh as well as from Andhra to be a part of this webinar, and we have been conducting regularly this webinar series. And today I have the great pleasure to welcome the chief guest for this webinar, my dear friend, Dr. Charulata. And I have the great pleasure and honor to welcome you, Charu. And I'm very pleased and pleasurable to invite and welcome the senior faculty, Madam Dr. Shashibala Bonsle, who is very well known for her very energy and enthusiasm. Welcome, Sashi. And the senior faculties, Dr. Vidya ma'am, who has been a great knowledgeable person who has been here to share her knowledge. We welcome you, Vidya ma'am, and a very great welcome to Dr. Aruna Suman, who is a co-convener of this webinar, as well as a very energetic and dynamic person, a right hand of Dr. Shanta madam. Welcome, Aruna, for your presence here. And a very special welcome and warm welcome to Dr. Bharti, who is here to join with us. And also a very special and warm welcome to all the senior faculties here. Dr. Mahananda madam, who has accepted very pleasingly to join this webinar to be the chairperson, and Dr. Pranita Ajay, who in midst of her very busy schedule today, the family get together, has accepted to join to be the chairperson. And a very special thanks to Dr. Vandana madam, who has been kind enough to join this webinar, and the Jagrati madam, who all have joined immediately to enthusiastically to give us support to be a part of this webinar. And a very special thanks to Dr. Shivakumar sir, who has been immediately accepting to join the panel, and Jyoti Karande madam, Nidhi Bajaj, Priti Sanjeev Gupta, Shabana Sultan, and Uma Deshmukh ma'am, who are all very much supportive and encouraging to join this panel. We welcome you all, madam, for this wonderful webinar. And I have the great pleasure to start this inauguration with a welcoming note to the chief guest, Dr. Charu, who has joined with great pleasure, because this month being a breastfeeding month, no other than Charu is the right person to be the chief guest for this webinar, who has been so much enthusiastically working in the breast committee of FOXI, who is heading the committee. And she was the clinical secretary of the Pune Obgyn Society between 23 and 24. She is the present director of the GEMS Hospital and Endoscopy Center, Ashwini Hospital, Pune. And she is the honorary consultant of the Deenath Mangeshkar Hospital, Cloud9 Hospital in Pune. And she has been trained in gynec endoscopy by Rakesh Sinha sir, and a training course in endoscopy in Kiel. And she has won the best video prize in IAG Hyderabad. And she has been a committee member of the GCFC Pune. And she is the recipient of the Smita Jog Award in 2019 for her exemplary work in the adolescent health. And she has won recently the Women Entrepreneur Award through Rotary Club Pune as a POGS Ideal 23. And she has awarded the MS Signature International Award 2022 for being the amalgamation of the amalgamation of the societies. Thank you. Thank you, Charuk, for accepting our invite. Over to you for your blessing for this webinar.
Thank you so much, Dr. Jayarani. Indeed, a pleasure to be here. More of a friend, more of a Foxian than as a chief guest, probably. And as we all gather today to celebrate the 76th Independence Day of our beautiful country, we also take the pledge, to free our women, give independence to our women from so many diseases, from so many disorders. And I think that reproductive health and sexual health are such an important part. And I can see, Dr. Jayarani, that this is your fifth series that you are conducting. That means your dedication to women's health is so immense that every Tuesday you're conducting these fantastic programs. So Dr. Jayarani, first and foremost, thank you so much for having me here amidst all of you. Dr. Vanita, that prayer and the introduction was so beautiful. It was indeed a pleasure to see the wonderful statue and the wonderful proceedings of the inauguration. You did it with great elan. Dr. Kundavi Shankar, Dr. Aruna Suman, Dr. Mahananda Padashetty, Dr. Shashi Bala, who's a dear friend, Dr. Vidya Thobi ma'am, I can see. Somebody who's going to talk on galactagogues, Dr. Raja Priya Ayappan, all the esteemed faculty, all the panelists, and dear delegates. Indeed, a pleasure to be amongst all of you here today. And as Dr. Jayarani said, that this is the breastfeeding month. And I'm so happy that not only my society, not only my committee, but the entire country is celebrating the breastfeeding month with so much of pomp and show, with so many programs, that the breast committee group is flooded with photographs. Somebody has conducted talk shows, somebody has conducted radio talks, somebody's on television, somebody has written articles in the newspaper. We hosted a big BreastCon 2023 in Pune, which had more than 300 delegates, which just goes to show that, breastfeeding is so important and is being accepted all over as an important topic to be discussed, not only by the lactation consultants or the neonatologists, but by us obstetricians, essentially because we have the first opportunity to tell the woman about the importance of breastfeeding, and we are the ones who are going to be able to guide her regarding breastfeeding. So along with the topics of male infertility and along with the important topic of panel discussion on cesarean section, I really must congratulate Dr. Jayarani madam for having included the topic of galactagogue in this particular webinar, because we all know that most young girls, they suffer from the problem of so-called less milk supply. So whether it is a perceived less milk supply or an actual less milk supply, what are the causes of this entire less milk supply? What can be done to help all this is indeed a big topic that needs to be discussed. And I'm sure Dr. Rajapriya will do a good job regarding that. The other topics which are going to be discussed today are also very important, about male infertility and, of course, the difficulties in C-section, which is our day-to-day, our routine obstetrics and routine infertility practice. We have to make sure that we are well updated regarding all these points. It is also a pleasure, I used to look at Dr. Jayarani only as a friend. I have been just hearing about her, but today when I saw her fantastic biodata, I now see why she is, such a big name all over, and I wish her all the best for her future endeavors. I can see Dr. Aruna Suman here, Dr. Bharti, and I really wish them all the very best for all their endeavors. And Foxy is good people. When I've come into Foxy just maybe 8 months back, and I realized that not only is it a great academic platform, but when you have a president like Dr. Rishikesh Pai and a Secretary General like Dr. Madhuri Patel, the sky's the limit. These are such fantastic president and Secretary Generals that you are given a free hand to do what you wish to, of course, with proper direction and proper guidance. And it has all culminated in the fantastic book on breastfeeding that we released at Kodaikanal. I really must thank Dr. Sampath Kumari for having given me that opportunity, and Dr. Rishikesh Pai for having pushed us, gently but firmly at the same time. And because of that, a private practitioner like me today has her name on a textbook along with Dr. Rishikesh Pai as the chief editor. So with these words, I thank each and every one of you for having me here as the chief guest, as I say, more of a friend, more of a colleague, more of a Foxian than anything else. I wish everybody best wishes for all their endeavors, and I look forward to each and every talk which is going to be presented out here. Thank you. Thank you. Series off and on as and when. And looking forward to doing many breast programs with Dr. Jairani and with the entire South. Dr. Vidya Thobi is here. She has also been a fantastic support to me. And I owe a large part of my success and my presence in Foxy to Madam, with all her constant guidance, with her words of wisdom. Again, with her kindness, with her knowledge, she has been guiding all of us so beautifully. And I look forward to doing many programs with the Kasoga also. She's given me a wonderful friend in the form of Dr. Lalita, who is also passionate about breast health, as most of us over here are now. Thank you.
Thank you, Charu, for this nice words, and thank you for all your vision in your breast committee. And definitely, we all, as a Foxians as well as the gynecologists, will work with you to bring this every women's life as well as the gynec's life better in all the aspects of breastfeeding, which is a very important part in the neonate in the initial stages of life, which is a very important one that as an obstetrician, we all should join together to improve and very much insist on the breastfeeding, definitely for all the women, all the mothers up to 6 months. So thank you so much for joining us and giving your words of wisdom. And it's been an honor for us to have you. And over to you, Vanita, for the academic sessions to start.
Thank you, Charlata ma'am and Jairani ma'am, for once again reinforcing the importance of breastfeeding and the awareness that needs to go down to the grassroots level so that every woman and every child enjoy to do that. Thank you so much, ma'am. That brings us to the end of the formal inauguration. Now we move on to the academic session. We start with session 1, decoding male infertility and the medical management. I invite the chairpersons of the session, Dr. Mahananda S. Melkundi, a professor of the Department of OBG, Kalburagi, medical superintendent of Kalburagi, a member of the Foxy Kalburagi Society. Madam is a present president of GOGS and the past vice president of Kalburgi OBG Society, and she's past treasurer of the same society and executive member of Foxy for many tenures. We welcome you, ma'am. I also take pleasure in inviting Dr. Pranita Ajay, who is from Madurai Medical College and has done an MD from Ahmedabad. She's a practicing obstetrician gynecologist from Ballari since 2000. Madam is a past vice president of Bellary OBG Society, and she's actively involved in educating high school children on adolescent problems for the last several years. We welcome you, ma'am.
And very interestingly, Dr. Pranita Madam is our alumni from Madurai Medical College, and it has been a great pleasure to see her. And it is so nice to get connected with her on this webinar.
Thank you, madam.
Over to the chairpersons, yeah.
Yes, ma'am. So, thank you, Dr. Jairani, ma'am, and thank you, the society. And it's my great pleasure to welcome Dr. Shashi Bala Bonsel, and she's the immediate past president of Gwalior OBGYN Society, and she's the national coordinator of IAEC Committee Foxy, and she's the consultant gynecologist in the Public Health and Family Welfare Department of MP government. It's a great honor, ma'am, to have you here. We welcome you, ma'am, to give a talk on male infertility medical management, ma'am.
Thank you. Thank you so much. First of all, let me thank Dr. Jairani for inviting me to this August gathering here. And I must say, even Vidya Thobi ma'am, even I'm very much indebted to her. And all the best to Dr. Jairani, Dr. Aruna, and Dr. Bharti. And I tell you, all these people will really upgrade the Foxy, I can say, because the bases will be the chairpersons. So thank you so much, Jairani. And Charu has been always with me, and breast committee is my weakness. And I have also contributed a chapter in that, and with Sneha I have worked. So now today, I take this opportunity to, like, the male infertility is something which has to be targeted. And this factor, I must say, I kept it heading as the spirited sperm. We don't want the sperm to be like, it should be the one who carries the torch forward, forward moving sperm we want, all of us want. So here we go. We have currently almost every seventh couple is infertile. And the male factor as the single or additional reason is there for infertility in nearly 50% of the cases we are seeing. We have so many army areas here, males are there, and they are actually, they have really, the stress factor has increased so much in the life of a male. So this there is a sudden spurt of the male infertility. Now, first of all, let me tell you about the definition. How do we define oligoasthenoteratozoospermia as OAT? The concentration and proportion of motile and morphologically normal spermatozoa below the reference values. That is how we call. And sperm idiopathic male subfertility, as we see, is the most common cause is free radical induced damage to the sperm. So today we are going to concentrate only on this factor of the male, that is the free radical induced damage to the sperms. So sperm tests we all have been doing so many times, but the DNA integrity of the spermatozoa has a critical impact. So the biology of ROS is there is production and there is degradation. So this pathology stems from the imbalance between production and scavenging. So we have to increase the production and downgrade the scavenging part. So this has a critical impact in determining sperm competence with ROS levels and may be measured by sperm DNA fragmentation assays. So chemical species with unpaired electron are capable to oxidize the lipid proteins and nucleic acids like superoxide anion, hydroxyl radical, hydrogen peroxide, peroxyl radical. All these are generated from aerobic metabolism in the mitochondria, and sources can be either leukocytes or sperms. So this is how we have to judge how to reduce the oxidative stress. Next, please. Now, the primary pathologies, as we are all aware, there can be systemic diabetes, cancer, systemic infections are on the rise. They carry the main thing. There is lot of oxidative stress. Now, male accessory glands, these are the anatomical or some infections acquired, prolonged stasis of spermatozoa in the epididymis or in the trachea. You know, all sperms are straight labile. So they need to be, the flow should be normal. If there is any epididylitis or any inflammation, that will lead to the impact on the sperm, everything, on the fragmentation, on the motility, on the morphology, everything. So we get immature, abnormal spermatozoa. So we have to target the root cause, that is the oxidative stress. Next, please. Now, environmental, we cannot get rid of this smoking, pollution, radiation, drugs, overuse. How to tell our guys, our boys, that boys, you can't take life for granted. You can't take sperms for granted. You have to take care of your sperms. That doesn't mean the onus is not on the female itself. So this dysfunction, spermatozoal infertility, has to be stressed upon the males whenever they come to see. Whenever the patient comes for an infertility, only the female walks in with her in-laws. So that has to be stressed, that equally the male has to be spirited, agile. Only the front, the exterior won't do. Next, please. Now, how do we go ahead? We first evaluate how is the oxidative stress. If there is diabetes or anything, cancer or anything, he's a chronic smoker, then we have to treatment of underlying pathology has to be done. We have to explain to him the avoiding the risk factors. It is very easy once the guys listen. Actually, it has not been told to them. When you do some better counseling, it really, really helps. I have seen that. And when I tell them, you have to cut down on the stress promoting ROS gene values, take some antioxidant, they listen. And nowadays, we are getting good results with that. Next, please. Now, the ancient enzymes, and there are some new insights we have been using. So, a lot of studies have been gone into to see how we can supplement antioxidants so that medically it can be managed. So, superoxide dismutase, this is one enzyme. Next, please. I'll show you how it works. So what is the role? It is an important component of antioxidative defense system and plays an important role in protecting the sperms from the oxidative stress. So pivotal role in metabolizing and forestalling formation of cascade of deleterious reactive oxygen species ROS. So it hinders the ROS to work and it just protects the sperms. Next, please. Now, to go into a little bit of details, this is SOD, superoxide dismutase, acts on the superoxide radical, converts it into H2O2 in presence of a catalyst, and then it converts into H2O plus O2. So, metabolism of generated oxygen radicals can be done this way. So, this is how SOD works. Next, please. Now, clinical trials have also been taken. So, this DNA fragmentation is the major contributor. And DNA fragmentation takes place because of the oxidative stress. So it is a major contributor to spontaneous miscarriages, first trimester abortions, recurrent pregnancy loss. We are at sea thinking what we are missing, where we are at fault. So you can keep on add on this to the meal also. And you have to take a history about his sleep pattern, about his eating pattern, about his what he wears, how much water. You know, even the males are not drinking water nowadays. They go on drinking all beer and all, and then they get dehydrated. So it's plain simple water also helps. So metabolism, so this is role of superoxide dismutase. It can improve the sperm quality by leaps and bounds. Next, please. So it is, we can consider this better than other antioxidants. We have so many antioxidants. I'll be telling you about them also. But this activity has been surveyed in the seminal plasma, and it can be a useful tool for determining sperm fertilization potential and could improve the diagnosis of male infertility. So next, please. So it's the first line, as I first told you again, I'm going to repeat it. Decreases the sperm ROS production, increases motility, improves the viability, favors the fusion, and therefore they restores the sperms which are there, but they are lying like listless sperms. Who needs? That's why I said spirited sperms we want. Just put some action into them. So now another one, SOD is clear, I hope. L-carnitine, it also increases the sperm parameters drastically, and we are using it for DNA fragmentation. And after the test, when it shows that there is some problem with the DNA fragmentation, then we do this and we get very good results. L-carnitine is always in that tablet also. It has been included. Next, please. Now Q10. Q10, we all know, we have been using it, and it has given us results, and it does improve the parameters drastically. It is a naturally occurring lipid-soluble compound concentrated in the mitochondria. So the mitochondria, I remember when we had gone to that VP conference last year to Goa, Madam Nandini Palshitkar madam had said the mitochondria, it is the mitochondrial energizer, coenzyme Q10. So this mitochondria is the main thing of the cell. So it has to be spirited, it has to be like propelled, and it acts as an electron carrier in the mitochondrial respiratory chain, helps in the transfer of electrons in the chain, and prevents lipid peroxidation and generation of ROS. So thus it stabilizes, what is important, stabilizes the cell membrane and maintains. Next, please. Lycopene, we all ask our patients to eat red tomatoes and have all these things which is rich in lycopene. Lycopene is also one of the very important. It improves the arachidonic acid and oxohexanoic acid ratio. So it improves the distorted ratio between A and DHA in the seminal plasma. So small things go a long way. 3 months of treatment, you just have to counsel the patient. It is just like a recharge to yourself, not only to the sperms. You recharge your whole thing, and they really feel a difference. They feel confident, they feel energetic. I've never seen males like this. Push, they are just sitting like that when they come to the chamber. Madam, kya bol rahe aap? So then when I tell them that this is how the whole being, your whole being will be serviced, then they realize that this thing has some potential and they agree to take, and we are seeing results. So it facilitates the spontaneous results in the IVF also. Next, please. So now we can also summarize that SOD-based antioxidant supplements, they improve the sperm DNA integrity than the classical antioxidant molecules. So this you have to include along with them. And lycopene is a strong antioxidant, prevents sperm damage. L-carnitine improves sperm motility. CoQ improves the sperm motility as well as the antioxidant, and multiple roles in prevention of sperm production. And zinc, I have not included astaxanthin. I have to include. I'm sorry, it is not in the PDF. It has a high antioxidant activity, and this extra. Whenever you prescribe for medical management for a male infertility, always see all these things. These 4-5 points are there, as well as astaxanthin, which is higher concentration it has got, and it can have an impact on prevention of various health complications also. And I have seen we get that even CRP levels done for male infertile patients, and this astaxanthin works on this C-reactive proteins also. So it is a keto-carotenoid and has the potential. And so along with vitamin C, we had Dr. Jindal with us last time on that wellness platform. There he was saying, please include vitamin C, vitamin E, selenium, zinc in all, even not for only for the males, even for the females. These are wonder vitamins and they have to be included. So thank you so much. I won't take much of your time on 15th August. And I had, so only this medical management I'm trying to tell you. There's so many things you all are doing. I know your infertility practitioners are here. But what I am concerned, at the base, first step in male infertility is you have to go in for this nutraceuticals, and always keep in mind that the fragmentation test has to be done. Thank you so much, chairpersons, and I hope you enjoyed. It was really very short, and just I wanted to tell you all about that. Thank you.
Thank you very much, ma'am, for such a informative talk on the medical management of male infertility, and explaining very well about the cellular changes and all the microcellular changes and the importance of stress factor in the male infertility. Thank you, ma'am. Thank you.
Thank you, Sashi ma'am, for that wonderful talk. Very crisply, very amply, all the components of this, what are the components that you have introduced very amazingly, very correctly.
I restricted only to the
very good. It's
only.
very good and very interesting for the gynecologists to know about it in a comprehensive way, that you have put it as a crisp bag with a crisp take-home messages. Thank you.
So always look for that antioxidant tablet which you are prescribing, that it has all these things. Then my thing is fulfilled.
You're right. Thank you.
All the best to all of you.
Over to Arna.
Good evening, everyone. I thank my sincere thanks to Dr. Jairani Kamraj, very dynamic person. She's an all-rounder. I saw her dance and sing 2 days back at PP conference at Kodaikanal, and she's academically also very, very sound. You can know that by looking at her CV. She has worked so hard. Thank you so much for the opportunity. And Dr. Charu and Dr. Pam, thank you so much for being with us. And your talk was excellent, Dr. Sashi, as usual. Thank you so much. You have given correct points. whatever the take-home messages you have given those without any extra. Thank you so much. And please let me have the CVs of the next chairpersons. I invite the chairperson, Dr. Jagriti Nagar, President Saga Obigine Society, Associate Professor. Why am I resounding? Associate Professor, Bundelkhand Medical College, Saga, and winner of Durusha and DK Tank Award as Secretary, Saga Obigine Society in Patna, AICOG 2014. Winner of the all 4 national awards as President, Saga Obigine Society in 2017 at Ahmedabad AICOG, and President in 2016. Part of organizing team of AMPOGS, several publications, and invited as faculty in many conference and high-risk pregnancy in is her area of interest. I welcome you, ma'am, to chair the session. And it's my pleasure to introduce Dr. Vandana Gupta. She is working obstetrician and gynecologist in Kathni for last 22 years, owner and director of Om Shanti Maternity Hospital, Kathni, President Cogs, founder and past Vice President Cogs, that is Kathni Obstetric Gynecological Society, Vice President IMA Kathni. I welcome you, Dr. Vandana Gupta. And the third chairperson is Dr. Rajapriya Ayyappan.
Speaker, ma'am.
Ma'am, may I
she's the
speak
speaker.
the speaker, ma'am?
Yeah. So over to the chairperson.
Over to the chairpersons. Good evening, Dr. Bharati Rashika, madam.
Aruna ma'am, you can just introduce the speaker. I think.
Okay. Okay. It's my pleasure to introduce the speaker today, Dr. Rajapriya Ayyappan, Managing Director, Om Fertility Center, Srinivas Priya Hospital, Perambur. And her positions are Secretary, Indian Fertility Society, Tamil Nadu Chapter, Secretary, Women's Wing, Perambur IMA, Managing member of OXY, Endometriosis Committee member of OXY, and Executive member of ATNRCOG and AFPSI. I welcome you, Dr. Rajapriya Ayyappan. Please take over the dais and present your talk.
Thank you so much, ma'am, Aruna ma'am, for that introduction. I must give my special thanks to Dr. Jairani Kamraj. As we all see, she's a person who has amazing energy, and God bless her with all the more energy. We're looking forward to seeing her do very well in these elections, because she is a person who's done tremendous work for the sexual health in Tamil Nadu. And I must say at the national level itself, because today, if we as regular gynecologists have some sexual health awareness, the credit owes to her. So with this, I would like to thank all these senior faculty who are out here to celebrate Breastfeeding Week as well as the Independence Day today. This is a lovely topic on galactogogues. And I must say, as gynecologists, we are fundamentally obstetricians. So once the woman delivers, there's a huge role of her getting the help to establish lactation, because it's bonding between the mother and the baby. So I would like to cover the topic as the definition and the various types what we use. It's basically a physiological activity, parturition followed by lactation. But then we give advice and what is the right food to take to improve milk supply, what are the herbal and natural ingredients, what are the pharmacological ingredients, and where are the particular indications where we need to use pharmacological indications. Coming to the very basics, the minute the baby is born, the suckling reflex is such an inherent reflex. You'll be amazed that the baby just wants to start suckling, and the minute the mother holds the baby against her breast, all these beautiful reflexes come to play. And the various important hormones, oxytocin, prolactin, all these come in place. Stimulation of the nipple by the baby suckling sends signals to the hypothalamus, releasing factors start happening, and then the pituitary, both the anterior pituitary and the posterior pituitary have two important lactation related hormones, prolactin for milk production and oxytocin for the milk letdown. And we all know that basically nipple also has a huge important role, and the erectile nipple nature is important so that the milk letdown happens. Now, keeping that in mind, all in our medical, no, it's like Greek and Latin, and this word also has a Greek origin, and various medications which are used to either initiate, maintain, or augment maternal milk supply comes under the term of galactogogues. Now, is really a galactogogue necessary? Should we artificially introduce it? Because it's such a natural physiological thing that's happening. Whenever the woman perceives or actually there's low milk supply, then it obviously needs to be intervened, because soon the mother will stop breastfeeding. She'll be afraid the baby is not getting enough milk and she will switch to formula feeds. So another thing, whenever adequate milk is not coming, it's a very depressing thing. The mother feels that she's failed as a mother because she's not able to feed her baby. So it's an immense connection where either the mother or the health professional seek medications. Now let's look at the various events which have to fall in place for successful lactation. Mammogenesis, a development of a good breast is important. And as I said, even the nipple, you need to have a good nipple, not a retracted nipple, for which estrogen and progesterone play a role. Then comes synthesis and secretion of milk from the breast alveoli, which is established primarily by suckling and then prolactin release. Then comes galactokinesis, the milk ejection by oxytocin, where milk is expressed from the alveoli. Then galactopoiesis. Once the initiation happens, galactopoiesis is continued as maintenance of lactation, where prolactin is an essential hormone. And once the breastfeeding phase is over, then the breast starts involuting. So all these are beautifully happening in the hypothalamo-pituitary breast axis. The growth hormone, thyroid, the TRH hormone also have a role to play in this. Now let's get, what is the relationship between prolactin and dopamine? It's like an inverse relationship. It's a negative feedback system where dopamine serves as an inhibitor. Once the breast milk production and the ejection starts, after that, it's like an autocrine mode. It happens more within the breast itself. So the rate of milk synthesis is mainly controlled locally. And once the breasts need to be drained regularly, and only if it drains, it starts refilling. If the woman is not emptying her breast regularly, then the milk production starts declining. So it goes a long way for us to explain to the mother that this is a natural phenomenon. She doesn't have to worry. And breast milk post-delivery is initially colostrum, then it becomes transitional milk, then comes the foremilk and the hindmilk with varied level of nutrients. And this is going to give all what the baby needs, and above all, immunity. So if the woman has a good talk by the obstetrician, whether it's a normal delivery or whether it's a cesarean, the minute the placental separation and hormone changes start, milk initiation also starts. It is best towards the third trimester to prepare her for effective lactation by telling her to clean her nipples, by telling her to massage her breasts, take good quality nutrition. If with animals, it's an instinctive behavior, even with humans, it's no less. It's an instinctive natural behavior, the suckling and the breastfeeding practice. But the modern woman needs to have knowledge about everything to be able to effectively do it. She needs the privacy. She needs to know how to help the baby to latch to her breast, the positions. And for normal delivery, there may be certain comfortable positions. For cesarean, there may be comfortable positions. Once the mother and baby bond and get into comfortable position, every breast, small, big, retracted nipple, every breast can be able to successfully nourish the baby. So this is key for us to tell. And as food, we always offer some amount of cultural practice, regional practice, religious practice, all this has to be respected. But fenugreek, garlic, fennel seeds, a lot of whole grains and meat protein, fish protein, liquids, all these play a role in effectively improving breast milk. And a lot of women get very anxious because on the first day they don't feed enough, not milk comes, then they understand that probably things are going haywire. We have to tell that the initial milk requirement for the baby is very less. And if the baby is passing urine, it fundamentally means that some liquids have gone in, and that's why the baby is passing urine. And the stress is something we have to alleviate as obstetricians, anxiety, poor diet, and other morbidity conditions. She may be diabetic or a hypertensive, or she's worried about certain complications in the baby, that it had some amount of meconium aspiration, things like that. So that worry or comorbidity factors have to be addressed. Do mothers need more calories during breastfeeding? Of course, because it is for her and for the baby. So an additional up to 400 kilocalories will be essential. So roughly 2000 to 2800 kilocalories per day is her requirement. And this is a demanding phase. So we have to understand she needs to eat sensibly and a balanced diet, and those diet which promote better milk production. What are the good practice recommendations ultimately? Nature is all powerful. So just talking to her, examining her breast and nipple whenever she's concerned it is not expressing enough milk, and showing to her that the pores are opening up and milk is actually coming. And as the baby feeds, the initiation and maintenance will automatically set in, telling her the different positions she can hold the baby. And if the obstetrician is not having enough time, it is worthwhile to involve a lactational counselor, because we have to explain to her his physiological process, and over 2 to 3 days time only effective milk production will happen. We should avoid straight away going on into galactogogues, especially artificial galactogogues, unless indicated. And if we start also, we need to have start-stop instructions. So women generally feel nothing is enough. There's always a feeling you can get more. So we have to understand the expectation versus reality, what's happening, and counsel them appropriately. So there are certain special situations, like when there is actually a low milk supply. There's a previous baby itself, she had problems with effectively giving them a 3 to 6 months proper lactation period. When there is suboptimal milk removal, she's not emptying her breast properly. She's probably not having enough knowledge on the position and latching issues. Maternal or infant illness, mother-infant separation. That's why we always tell, whether it's a normal delivery or cesarean, keep them together, avoid separation. Rooming in, bonding, all these are important. But if there is a sick baby or a preterm baby and it is in the NICU and she's forced to express milk and send, it can be a very traumatic. And the minute it's not more in the breast, it's actually in her mind, the mental belief that I can feed, my milk will come. That is important for us to talk to them. So using a hand pump or a breast milk pump, we have to understand how she effectively uses it to be able to give a good milk production. And when there is no suckling, there's no natural stimulus, that should be explained in difficult situations. So today, with enough motivation, even through a baby born through surrogacy, transgender, all of them are making attempts at breast milk feeding. Now we just discussed the various indications where these galactogogues are indicated. And once the lactation is established, once milk starts coming, we don't have to keep continuing these agents. You can slowly taper and stop it as soon as possible. And one of the important ways of assessing it is good urine output from the baby. And once the pediatrician is happy with the baby's growth, then we do know that she has effectively established lactation. And there are some amazing women who are able to breastfeed their babies, not just 1 year, 2 years, even up to 3 years, but at least 6 months, whether it's a working woman or not, we must encourage them to give breast milk. And today we have modern tools like the breast pump and advice to them that how they can store their breast milk and things like that. So let's get into the pharmacological galactogogues first. It's the growth hormone. TRH is there, but common agents which we are using in clinical practice, I wouldn't say we are using them commonly in practice, but the agents available rather, which are pharmacologically relatively effective, is domperidone, metoclopramide, and antipsychotics do affect the breast milk. And these are the situations which we say in the gynec practice when a woman complains, I have galactorrhea. And if you look into a history, you'll be finding that she'll be using some antipsychotics, and they all work at the level of the dopamine receptors. Looking at domperidone, what is the Cochrane evidence? If up to 30 milligram per day is used, depending on the woman being a responder or non-responder, anywhere from 80 to 90 ml of additional milk is possible by the woman, which was not there before. So it's of some moderate benefit. But what are the side effects? They have gastrointestinal side effects and some amount of cardiac side effects, which we have to have caution. And initially, cardiovascular side effects like ventricular arrhythmias have been observed with IV use. And in United States, in fact, there is an FDA advisory against the use of domperidone in lactating women. The common side effects are GI side effects, skin rashes, and headache. So we have to have a lot of caution whenever using these pharmacological agents. Coming to metoclopramide, after various doses, 30 to 40 milligram is seen as an effective dose. And there are some studies which do not support it as an effective galactose. There are few which say, yes, it does have an increase in motility. Now, what about the side effects? Diarrhea, nausea, seen as side effects, anxiety, depression, and headache. The concern is the extrapyramidal symptoms. There are rare cases of these particular problems, dystonic reactions, for which the FDA has placed a warning that it is best avoided. The more popular in India, I would say, are the various herbal preparations like fenugreek. They call in Tamil as Vendayam, fennel, or we have that soft seeds, and shatavari, goat's rue, anise, and in Indonesia, like each country has their own popular herbal ingredient. And these come as herbal preparations. So we generally encourage the women to mix it with water and milk and consume it 2 to 3 times a day. And as lactation gets established, to slowly taper it down. So how often they use it depends upon how effectively milk is coming. And once the milk starts coming, effective feeding, removing the milk from the breast would keep the maintenance of the lactation happening. So with respect to premature hospitalized babies, anatomic problems, then we know the things will be difficult. Ensuring that breast pump is effectively emptying the breast is important. So galactogogues will not increase the milk supply whenever there is inadequate breast drainage. So these kind of important things should be counseled to the women. So introducing galactogogues, risk versus benefit ratio should be studied, especially when you're using pharmacological galactogogues. There will be drug to have interactions. Overall risk benefit approach should be seen, and the women should be informed that this is what they are actually involving. So best avoid galactogogues and focus on latching, keeping the baby close to them, bonding and things like that, and having a positive physical environment and a mental environment. I can do it. I'm going to feed my baby. These are simple words, talking to her mind and making her believe that she can be an efficient lactating mother. But if you're using the galactogogues, how much of time you're going to use, the duration of therapy, take enough opportunity to bring them out of the galactogogues. So I'd like to conclude my presentation saying that selected indications only, we should introduce galactogogues. Current data are insufficient to make strong recommendations. So use for the minimum time till lactation is fully established. Never abuse or overuse such that breast engorgement happens. So that's absolute folly. In a place where she should be happily breastfeeding, you shouldn't create a sore and engorged breast. So thank you so much for your time and listening. And I think the most important is the mother getting support from the husband. No, it is so important that when the breastfeeding policies of the government and helping women when they travel to be able to feed the baby, which affects breastfeeding to be continued to as long as possible. So nutrition, family support, the bonding between the mother and baby, and above all, the obstetrician's early counseling and the mother's faith in her own self that she is going to do it with all the love and passion possible. Like Jairani ma'am having all her love and passion for sexual health, not only for men, also for women. I think that's again something important, that women deserve to be respected, and that should be respectful breastfeeding policies. So thank you so much.
Thank you, Dr.
Very
Rajapriya Ayappan. Very, very nice talk you have given. This is not frequently covered topic. I thank Dr. Jairani for thinking about this topic. This is so important. And you have given us so practical points. Whenever we do rounds, the women will be having so many doubts. My milk is not sufficient and the secretion is not proper. What do we do? So definitely we have to talk to them, right? And give them confidence what exactly is going to happen. And regarding the diet, you have explained very well. Thank you so much.
Thank you.
Very
Word from the
crisp,
chairpersons, please.
very crisp, informative, excellent talk, madam. You covered all the aspect beautifully. Thank you so much, ma'am. And all the best, Jairani ma'am.
Thank you, madam. Thank you, madam. One is Jagrati madam is here.
Yes, ma'am.
Oh,
That is Jagrati only.
oh, I couldn't see you. Your video is off. No, we don't know. Everything is given as doctor.
I
We
know.
don't know. Exit.
That's a confusion here.
Yeah,
All
everybody
doctors
is-
say, yeah.
We couldn't see your video, ma'am. Yeah. Thank you, ma'am. Thank you for joining us, giving your valuable opinion. Thank you. Thank you so much. Vandana, ma'am, your few words. I think she's not there. And you're so
Vandana
nice,
from
Rajpriya,
Katni.
for giving a
Katni.
very...
Vandana, I think she's there. Vandana
Yeah,
ma'am.
yeah. Vandana, ma'am is...
Jagrati, is Vandana there? I just saw her.
Yeah, ma'am, she's.
Everything is coming as doctor, and that's why I put a rename for that so that we can know the video is also off. We don't know who is there. And it was so nice, Rajpriya, that you have made very clear about all the practical tips, which is very important for an obstetrician point of view, especially as rightly pointed out by Aruna, the postnatal ward, the postnatal stress of the women itself is the breastfeeding, and especially when it's a multiple pregnancy, they are still more stressed. And you have clearly said about all the drugs, what to use, how to use, what is an FDA approved. And it is really good that you showed everything very practically. Thank you for this nice deliberation, Rajpriya. And we move on to the next important session, that is the panel discussion. I'm sorry, initially we put it as a breast and everything about the breast, but some difficulties were there. So we just start the difficulties in cesarean section, one head above. Before the lactation, we come to the delivery. So we are here for the panel discussion on difficulties in cesarean section. We have with us the two great doyens here to moderate this panel on difficulties in cesarean section. We have Madam Vidya Dopi, who is the president of Kasoga, who is a professor in Department of OBGYN of Alamin Medical College, Vijaypur. Madam was the chairperson of the Food and Drugs Medical Surgical Equipment Committee in FOXI between 2018 and 20. Madam has achieved the Best Committee FOXI Award, Dr. Meru Darad Hanasuti Award on 2020. And she was IC Governing Council member 21-23. And she has gained the FOXI Champion Award in 2019. And she is the National Corresponding Editor of Jogi, Organizing Chairperson of Kasoga 2016. And he was the president of Vijapur OBGYN Society 2009 and the secretary of the same society in 2007. And Madam had published various books and contributed a lot of academic accolades in FOXI. And she's a very very eminent national speaker in various national and international conferences and has presented various papers in the national and international conferences. And she's a postgraduate and undergraduate teacher for more than 30 years. And we welcome you, ma'am, for your panel. And we have another doyen who is there from Telangana, Dr. Aruna Suman, who is the professor in HOD and the vice principal of the Government Medical College, Jagitial, Telangana, who was the joint secretary, FOXI 2021, a zonal coordinator of FOXI 22-23, and vice president of Hyderabad Society 2020-23, the treasurer of TCOG 2022-23. And she's the trainer of the health programs, National Health Mission. And she's a very important person in the National Quality Assurance Standards.
Thank you, Dr. Jairani.
So over to the moderators for this panel.
Madam is having a little problem with her internet. She will join us in between. Yes.
Oh.
But definitely she'll be there. So we both will continue with this panel discussion.
You can't hear me, Aruna? You can't hear me?
I can hear you, not you. I'm talking about Vidya Topi, madam.
Oh, Vidya Topi, madam. All
She
right,
is having problem with her internet. Now and then she'll join and let both of us continue with the panel. Okay, panel discussion.
Sure. So will you introduce your panelists, or can I go ahead with the panelists? So we have with us the panelist, Dr. Bharti, who is the medical director and OBGYN consultant of the she's a president-elect of Kasoga 23-24, past honorary secretary of Kasoga 21-23, and she is a Sahadya Multi-Specialty Hospital Hazans medical director and consultant. And she has various awards and she holds various positions in IME and also in the Hazan OBGYN Society past president and the PCPNDT committee member. And she was a member of the FOXI Food and Medical Equipment Drug Committee. And she has done a lot of programs with BIRA. She's a trainer of the FOXI BIRA program. And she's the member of AHPI and HSCC. And she had a lot of awards and activities. And her special interest is adolescent health and high-risk pregnancy and family welfare and contraception. Can I have the next?
She's not there. Dr. Bharati Rashikar is not there. She had to leave for her emergency.
All right. Okay. So we have Dr. Jyoti Karande, who is the secretary of the Indoor OBGYN Society 23-23. And Madam is the member of FOXI Quiz Committee. She's an examiner of the MRCOG Part 3, and she's a joint secretary of ACOG 22 and the BreastCon 2016. She's a life member of IFS, IMS, and IZARD. She's a COVID Kathak dance from Kalikar University, ex-consultant of the Manipal Hospital, and she's a quiz master in various national and international state IZARD conferences, and she's the vaginal surgery workshop coordinator, and she has been an editor and a contributor in various many journals and books, and she has been a faculty on national and international conferences. We welcome you, Jyoti Madam, for this panel. And we have our Nidhi Bajaj, who has been so much seen in many of the very academic, many webinars. I've been with her. It's nice to have you, Dr. Nidhi, here. She's an endoscopy gynecologist and an OBGYN and an infertility specialist and a fellowship in reproductive medicine. Madam is the director of the Sparsh Multi-Speciality Hospital, Katni. She's the secretary of the Katni OBGYN Society, and she has a lot of publications. One among is the terms of uterus in complicated ventral hernia. She has done in JPGO Volume 1, which is an issue which was published on March 2014. And she is a member of MOGS, FOXY, COGS, and PCOS Society. And she has a lot of social activities. And she has done a lot. She has got an award, the Foxy Young Talent Award in West Zone in UI Foxy 22. We welcome Dr. Nidhi Bajaj for your presence. And we have here one another young, dynamic Dr. Preeti Gupta, who is a award-winning obstetrician and gynecologist over the past 20 years of experience. Madam is the expertise in ultrasound and infertility specialist and endoscopic surgeon. And she is the secretary of the GOGS, and she has been a faculty of ACOG and state conferences. She is the past executive committee member and the joint secretary of COGS, and she is a life member of IFS, IMA, IZARD, and she has published more than 10 papers in the national and international journals, and she has a working experience of more than 30 years. And she has got a lot of awards like Young Doctor Award, Nari Shakti Alankaran Award, Anand Bhai Joshi Award, and COVID Warrior Award, and many other accolades. Thank you for joining us, Dr. Preeti.
Thank you. Thank you, ma'am.
And we have Dr. Shabana Sultan, who is the professor in the Department of OBGYN, Bhopal. Madam has presented many papers in the national and the international conferences, and she has published many papers in the journals, and she is the member of esteemed team of PPH Bundle along with Sevagram, past joint secretary of Bhopal OBGYN Society, past treasurer OBGYN Society of Bhopal, and present secretary of Bhopal OBGYN Society, an executive member of Madhya Pradesh IZARD, and she has done various international projects along with Harvard University, and her special interest is gynec oncology and high-risk pregnancy, and she is the master trainer of cervical screening program. We welcome you, Shabana Madam, and I have the great pleasure to welcome Dr. Shivkumar, who is actually associate professor of the Vijaya Nagara Institute of Medical Science, Bellary, and sir is the consultant of the Siva Super Speciality Clinic in Bellary, and he has a lot of professional briefs and awards. He has the best poster award in NatCon 2014 in Chennai for his paper on primary peritoneal malignancies, and he has awarded a third prize for his paper presentation on staging of cervical cancer in NatCon 2017 in Bangalore in the second Indian Cancer Congress. And he had more than 6 publications in oncology, and his special interest is breast and the gynec oncology. And he has a lot of affiliation to the IMA, AGOA, ISO, FOXY, and he's the present secretary of KC, AGOA 2021 and 23, president of the Bellary OBGYN Society 23-25. We welcome you, Shivakumar sir, for this panel. And we have Dr. Uma Deshmukh. Madam is the HOD of the OBGYN Brimer Sridhar Bidar of Bidar. She is an advisory committee member of PCPNDT Bidar district from 1996 till date, that is 2020. And she is the national officer of the maternal mortality of the Bidar district 2007 onwards. Madam is the trainer for the EMCH in collaboration with the Singapore team. Madam is the IMA Vice President year 22-23. She is the president of Box Bidar 23-24. Madam is the executive committee member of the Women's Doctors Wing, and she is an instructor of Jeevaraksha ECLS training for medical students. And she has received the Best Doctor Award from the from Endangered NGO Bangalore in 2019. And she has received a lot of awards. One among is the Sarvottam Seva Prasthi from Government of Karnataka in January 2020, and also from Sharan Baswa University, Kalburgi in 2020, and received Aspiring Women Award in 2021 for from Vegan NGO Bidar, and received Appreciation Certificate from the Rotary Club of Bidar 2022, and also has received Appreciation Award from the Karnataka State Government Employment Association, and very much appreciation certificate from the IMA Bidar. Madam is having so much of laurels to get so many awards. We welcome you, ma'am, for all your knowledge sharing here. Over to the
madam.
moderator, Aruna and Madam Vidyadevi.
Yeah, can you share the presentation? Do you have the presentation or shall I share?
Vanita, you have it or Madam can share?
No, ma'am. Aruna, ma'am, you will have to share it, ma'am.
Okay, right. You can see my screen, right?
Yes, ma'am. We can see it, ma'am.
Okay. Okay.
I think you have to put in the slideshow.
Yeah, I put it in a slideshow.
Ah, yeah, right.
Okay.
Correct. Yeah, now it's right. Perfect.
Okay. So we all know that there is a tremendous increase in the incidence of cesarean section. Actually, according to the WHO, it should be 15%, but right now it's almost 70 to 80% at some places, especially in Telangana where I work, it's highest. So we need to bring down the rate of cesarean section. Definitely we all will have to work before continuing with the difficulties. And usually the rising rates of cesarean section has no improvement in the perinatal or a neonatal morbidity or mortality. So we need not do a cesarean section for everything. So definitely there is a increased morbidity and mortality. Okay, let's directly go to the panelists, my esteemed panelists. Okay, this one. She's a primary gravida, 38 weeks in active labor. There is no progress of labor even after 2 hours with delayed engaged head. Decided for cesarean section. What is the methodological approach to this surgical difficulty? Starting from skin incisions, difficulties faced when entering the abdomen. So what is the methodical approach? Dr. Nidhi, you want to take someone?
Yeah,
take it up,
I would like to go with a fenestrine incision only,
okay,
because it is almost like a second stage.
So
probably the bladder will be high up. So need to be, the UV fold has to be need to be opened up, and we may have to deliver the baby by modified Patwardhan's method, because head is deeply engaged in this case.
Now let us see what is the first skin incision you are going to give. Initially, what is the best type of skin incision?
Ma'am, I would prefer a Fern steel only.
Fern steel. Okay.
Yeah.
Anyone is there?
I am also.
Everyone, all the panelists, you want to give Fern steel incision or something else?
Yes, I will.
Okay. Okay. Then starting from the skin incision, suppose it's a previous one section you want to enter it. There are a lot of adherence.
Yeah.
The actually anterior abdominal wall is adherent to the uterine wall, and you don't know where the bladder is. You don't know where the bowel is. So how are you going to enter this?
I would like to go with the lateral approach, ma'am. In this case.
Okay. So
hello, this one is primary gravida, no, madam?
Yes,
yes, ma'am.
Yes, this is a primary gravida. Suppose I'm asking if in a difficult entry case, how are you going to enter?
No,
I would like to go through a lateral approach, ma'am.
Okay, lateral approach. Yes, agreed.
Vertical incision we have to take.
Vertical or transverse?
Additions or not. So we have to go by the fenestrine incision, and then when we cut the rectus, we have to take it with the higher approach to cut the rectus and the that median incision.
Okay.
We have to take the higher approach through the rectus and then opening the abdomen.
Okay.
Ma'am, this patient is in no progress for 2 hours. So before starting surgery, I would like to have a very nice assistant, because there may be problem in delivering the baby. A pediatrician should be ready and informed that there may be difficulty in delivery of the baby. put a
Yes,
proper
Dr.
position, and then proceed for that would be the methodical approach, because we are expecting difficult delivery of the baby in this situation.
And I will take the incision in the uterine incision high up only.
Yes.
And I will separate, and I will try to take the baby from the foot because it is deeply engaged. I will try to remove the baby from foot.
Uma ma'am, please tell me,
Yes.
how are you going to identify the lower segment? Here it is very important. The bladder will be drawn up. So how can we identify the lower uterine segment?
No, it will be loose hanging. It will be up to above only. It will come high up. Just when we'll take, it will be high up. And so that's why I will separate the bladder and I will take the incision above. It will be almost, we can't, if we'll take below, I will separate, I will push the bladder down, but it will be thin lower segment. I will take the incision upper, almost just below the upper segment, high up. Then I will remove from the foot. If the deeply engaged head is there, I will remove the baby from the foot.
Yes, let's go about that later on. So here we have to identify proper lower segment, give the incision. Starting from skin incision, which is the best, we'll see. So you have told us how to deliver the deeply impacted head. Uma ma'am, can you please give us more methods?
Patwardhan technique, one is Patwardhan technique. If the back is front, then we have to remove it from Patwardhan technique. If it is the side, we have to remove from the foot.
Okay, so one you said directly by doing the breach.
Yeah.
Okay, but with the breach, you catch hold of the feet, pull them and deliver.
And pull them.
Second is
if the back is completely anterior, then we have to remove it from the Patwardhan technique. First, to hold from both the this one shoulders below that back, then remove the first buttocks and the foots, then head.
So basically, they can be divided into push methods and pull methods. Push method is from pushing from below, but it has been found to be having more
deeply impacted head is there. It will be difficult.
So it will be difficult. So pull methods, all the pull methods are better.
I'm in a webinar. I'll call you
for the baby.
Okay. Actually, see, there is any other method which is not really advisable. Like, can you ask the assistant to push from below and you deliver from the above?
It can be done, but then if it is done with 2 fingers or not an experienced person, it leads to a lot of lower uterine tear.
It's very difficult. Yes.
Yeah. And extensive tears in the lower segment.
Okay.
And babies also doesn't do very well. So Patwardhan or reverse Patwardhan is better.
Better. So let us see what the evidence says, because there are few studies given in 2021, according to the Cochrane. What does it say? So there are difficulties at various levels and technical difficulties are faced when we are opening the abdomen. So the incisions are Pfannenstiel, Joel Cohen's, Maylords, and Cherney's. Cherney's is given in obese women. So these are the indications. So Joel Cohen incision is preferred compared to Pfannenstiel. Why? Because there is less fever, less pain, less requirement for analgesics, there is less blood loss, and shorter duration of surgery and shorter hospital stay. So the use of analgesics is also very less according to the evidence. So they say the Joel Cohen's incision is best, which is just 2 to 3 centimeters below the anterior superior iliac spines. Okay. What about the uterine incision? You should tell me if you want to extend the uterine incision because you are having a difficult delivery. What would you prefer, the J shape or the U shape incision? Doctors, please tell me.
I prefer the J shape.
J shaped. Inverted T is preferred.
It causes more hemorrhage and later on more chances of rupture. So J shaped is preferred.
J shape is preferred, ma'am.
So always J shape. Suppose still you are having a problem, we can give U shape rather than inverted T. Inverted T shape should not be given. You should avoid that because the rupture will be more common. Okay. Coming to the deeply engaged head, it is the fingers of one hand initially you have to try this method. Fingers of one hand are insinuated between the fetal head and the cervix and the vagina. The fingers are wriggled gently, and you try to take out the baby. With the hissing sound, the fetal head can be delivered sometimes. So first, initially you disimpact with your hand itself, with no one pushing from below. If that is not possible, then you can use all the other methods, which is push and pull technique. The upward pressure by the assistant, this is not used, and the Patwardhan techniques, or directly the feet also can be delivered, as madam said. This is modified Patwardhan's technique. Okay. So the hemorrhage due to extension of the incision requiring the blood transfusion occurred in 24% of the patients in whom head was delivered first, as compared to those who are delivered by Patwardhan technique. So the Patwardhan technique is safer also, we can say. In this situation, there was a vertical extension of the incision underneath the bladder, which is not approachable. How are we going to approach it? So you have delivered the baby, deeply impacted head. Well, you wanted to suture. There is a vertical tear, which is going underneath the bladder. So how do we identify that? And how can we suture? Shivkumar sir, can you please take that?
Vertical incision underneath the bladder, which is not approached.
No, we have given a transverse incision, but you have delivered the baby. Now there is a tear in the lower segment, which is going underneath the bladder. So how are we going to identify the tear?
We should have very much patience now, madam, during the intraoperative period, and identify the lower segment properly. Slowly take a stay suture at the vertical.
Yes, sir. Yes.
Stay suture you take at the vertical incision, and slowly pull the bladder with the Babcock forceps, and meticulously do not blunt dissection, fine dissection, so that you can get the apex. Once you get the apex,
okay, sir. Right, sir. Agreed.
Above the apex, we have to suture.
So initially, suppose the lower segment is very much stressed, we can put a stay suture before giving a incision. That's more important, so that sometimes what happens, the segment, lower part of the incision, the uterine segment will go into the bladder, and you will be suturing sometimes only the bladder peritoneum. That can happen. So we have to be careful, and we can put a stay suture. And one more thing is, suppose there is a vertical tear, you should put a stay suture, pull it, wherever you are able to see it, start suturing, and finally you will be able to identify the apex, and you can suture that way. Okay. So first of all, can we exteriorize the uterus or not?
Yes.
Routinely, do we exteriorize or not?
We are exteriorizing.
Ma'am, it
We
depends
This
on the
situation I would do.
expertise of the
Again,
doctor
according
actually.
to the Cochrane review, latest review says you can exteriorize the uterus. Initially, we thought that would increase the febrile morbidity, but it won't increase. We can do it. Okay. In this case,
situation, at least you should do. Whenever
Yes.
there is excessive bleeding, we are not able to see the structures properly. Even it helps in massaging and reducing the
yes, Dr.
bleed.
Jo.
Even posterior wall of the uterus, we have to see.
Yes, that's very, very important, because sometimes we can miss some tears in the
Yeah.
posterior aspect. So initially we can see, and you can see the adnexa also before putting the uterus back.
Yes.
Coming to the second case, she's gravida 2 para 1 live 1 with previous section with floating head. Sorry, posted for elective cesarean section. How would you handle this?
In case of floating head, in this case also, we have to bring the baby's head at the uterine incision site. That is more important. So taking an incision on the uterus is more important, where we should.
So that means you're going to stabilize the uterus.
Stabilize.
Either the assistant who is assisting you
Assistant
can
has-
stabilize because by a lateral push, or by a anesthetist who can stabilize the fundus. Yes, sir.
Once
Yes.
stabilize, take an incision,
Okay.
And slowly suck the amniotic fluid till the head descends down.
Okay.
Descent of the head is most important. It should descend and come to uterine incision site, and then flexion has to be maintained by our hand. Then
Yes,
we can extract the baby. With this manner, we can extract any floating head without difficulty. Meanwhile, fundal pressure has to be given with the lateral grip. Sometimes we may feel difficulty. In the cases, we use a Vectis, single bladed Vectis, or we can use
Ventos.
Forceps.
Forceps or Ventos.
Ventos, forceps, yes.
Or we can use Ventos also.
Very well said, sir. Yes,
The
that
main
is how you
principle
have
is
to.
the baby has to descend to uterine incision and flexion has to be maintained.
Yes, sir. That's very, very important point you have brought out. Flexion should be maintained always. Okay, sir. Suppose the head is difficult to deliver, we can deliver by breech. Yes. What is Misgav-Ladakh's technique? Do we advise this technique? And what is modified Misgav-Ladakh's technique? Anyone can take up, please, few points. We all know it is given by Misgav-Ladakh technique. Misgav-Ladakh is a hospital at Jerusalem, and this is started by Michael Stark, and he presented a paper at FIGO 1994, and this is well accepted. But only one thing is we can make few modifications.
Rectus muscle is opened with the fingers.
Yes, that is
The
Joel
peritoneum
Cohen
is opened with the index finger
Dr. Nidhi,
stretching.
that is Joel Cohen's incision, which is a blunt incision.
Blunt dissection.
Minimal instrumentation, you just
Use.
stretch it so
Yes.
that there is minimal injury to the bladder and underneath vessels also. Even the superior vessels also, they are not
Even
injured.
peritoneum, they will not suture.
Yeah,
Yes.
peritoneum is opened with the index finger, and the uterus is closed in only in single layer.
Single layer.
Peritoneum
Yes,
is left
but it is
unclosed.
now modified. We can use the double layer instead of it. And
In
the
modified-
peritoneum is not sutured.
Not sutured in any of them.
So how many of you suture the peritoneum?
No,
You all
we are
suture?
not suturing.
Nobody.
Okay, because our senior professors say always you have to, whatever you cut, it should be sutured. But we have never sutured, you should stop it. Why should we not suture the peritoneum? What happens if you suture it?
More additions and
More adhesions, more pain to the woman, more need of
Infectious
analgesics,
morbidity.
more days of hospitalization.
and
So
more
all this
infectious
can be
morbidity.
reduced by this. Yes.
So the peritoneum basically heals by centripetal form. So that
Yes,
it
because
heals
it's a
from
weak
outside to
bacteria.
inside.
By almost 48 hours, it will heal. That's why
Heal.
no need
Yeah.
of putting the peritoneum.
And next time when we open, it is very short if we have sutured. So we find there is absolutely nothing, no space to open also. Very dense additions.
But still, some of my professors say whatever you have cut should be sutured.
Yeah.
They suture even the muscles. So the women will have lot of pain if we suture the peritoneum and the muscle. And next, it's a big baby. During cesarean section, big baby, the breech was delivered easily. Problem is after coming head. How would you deliver the after coming head?
Same principles.
Same
Like-
vaginal delivery principles.
Suppose, no ma'am, actually you have delivered the baby completely, the trunk is delivered, but head, the uterus is catching the head. So however, it is entrapped. So how are we going to tackle this problem? One is forceps we can use.
Yeah.
And again, we can give the U-shape or J-shaped incision. And we can ask the anesthetist to give
Relax the uterus.
relaxant. Like what are the relaxants that we can use?
Halothane.
Halothane or the nitroglycerin.
Glycerin.
It's a transverse line. She's on the table. So what are we going to do? How are we going to reduce the morbidity and mortality? Transverse line. She's in labor. You want to deliver her. You're doing a cesarean section. So from the beginning, what are we going to do? She's on the table and you have washed up. You're ready to operate. So what are we going to do now?
Incisions are the same as we are giving the incision fenestrine, and we enter the peritoneal cavity.
For that, you're going to do something.
No.
Dr. Jyoti.
Like before, we should try to make out what is the position of the fetus, where is the back,
exactly,
what is
Where is the
anterior,
head
back
and
and
where is
head.
the back?
The head and where
That's
is
more
the head?
important.
Yeah, that is
That's
more
more important. Dr. Uma Madam is
Yeah.
saying you have to identify which side is the head
And
and which side is the breech.
yes,
So that directly after giving incision, you can put your
Where
and
hand.
even
we can
before
direct-
giving incision,
Pull
we
it
can do version type to bring breech down. So that will be very easy to.
Okay.
If
Right.
it is relaxed uterus, we can do it.
Yes. Yes.
And
Definitely.
where the foot is there, that there only we have to go and extract the foot.
Belly button. Yes. Okay. So the next question is, there is a case of placenta previa without eccrita. How can you plan for the delivery of the baby and control the bleeding during cesarean section? So it's a case of placenta previa. How are we going to manage that?
Repeat technique.
So first we have to arrange
to
for
give
blood,
blood
cross match,
assistance.
give Trenexa before starting surgery, keep a good assistant, take a proper consent, and then proceed. Then we can
the
either
blood, keep the blood ready also.
yes.
Okay, then what are the few steps? You know, this is a case of placenta previa. There is no eccrita, but you want to deliver properly without any morbidity and mortality to the baby and the mother.
Ma'am,
try
first
to-
the localization of the upper placenta
Ah.
should be done. One.
Yes,
Then
Nidhi,
healthy
agreed. So
devascularization,
you have
and third
to
is placenta.
localize the placenta, see for the placental border.
Margins.
Okay, agreed. Then when are you going to happen? At what place are you going to give the incision? What site?
Just
Yeah,
below
upper
the lower edge.
It depends.
Upper
If it is central, then we have to go above.
No, sir is
Otherwise,
saying something, sir.
at the upper edge of the placental margin.
Exactly correct. After identifying the border of the placenta, 2 centimeters above that, we are supposed to give the incision. We are cutting through the placenta is not allowed now. So you don't do it now. Okay. Then you deliver the baby. Suppose the placenta is separating, it's okay. If it is not separating directly, you have to do a hysterectomy. You should not meddle with the hysterectomy. By pulling
Removing
the
the placenta.
too much,
Yes.
if it is adherent. Okay, thank
We
you.
have to take the consent of the hysterectomy prior to the start of the surgery.
Yes,
Otherwise,
high risk
there is
consent.
mishaps during the surgery.
Yes, agreed. And what is the role of doing this uterine artery ligation or the internal iliac artery ligation? In this case,
in many cases, internal iliac artery ligation helps, madam. We usually extract the baby, and after extracting the baby, we will do internal iliac artery ligation.
Okay.
The
Okay, sir.
placenta separate out easily. It will stop the. It will reduce the bleeding in most of the cases.
Okay.
Even if the placenta is not separated, some increta or purpura is there. Even cesarean, if we do cesarean hysterectomy in those patients, then also bleeding will be less. It
Yes,
takes
sir.
3 minutes extra.
Is there a role for doing P-Lynch or the Chose sutures here?
That is for atonic uterus. That
Bleach for the atonic uterus.
For
Yeah,
this
P-Lynch
placenta previa, can you do?
if it is like
Chose-
lower
chose
segment is
suture.
bleeding
No,
locally,
no,
we can
ma'am.
apply a suture and try just at the local point. If it is a very small
Where
area
the
which is
open
bleeding,
placental sinuses are there we
then
can
it's no
suture.
use.
Yeah, we can suture
No
the,
use. Just only once place is bleeding spot that we can try to like it with a suture. If the whole blood is bleeding, then it is no use.
But according to some studies, they say P-Lynch or
P-Lynch,
modified P-Lynch, Heyman
It
suture can be put.
will
And
compress anterior and posteriorly.
Yes.
It will compress and the bleeding will stop.
Yes, ma'am. Uma ma'am, yes, agreed. That's
Yes.
what the
Yeah.
latest literature says. So we can
Yes.
do that.
we
And
have to
coming
suture
to
the end and the posterior wall of the lower segment together.
Ah.
That will also stop the bleeding.
So in this case, she conceived after infertility treatment. There is a fibroid in the lower segment at the site of the incision. So what are we going to do? Are we going to remove the fibroid at the
Yes.
site of the incision? How can we proceed
First,
for the
we have
surgery?
to deliver the baby
Okay.
and
No,
we
no.
have to cut.
Suppose at the site of incision, that's why I made a point saying that at the site of incision, there is a fibroid.
But ma'am, we can't wait for the deliver the baby before. We have to do the myomectomy after the delivering of the baby.
Okay.
So we have to take the incision
Up or down?
2 centimeter above the.
No, if it is big and it is obstructing, we can enucleate and we can remove.
Exactly correct, ma'am. Uma ma'am, yes, I think you have more experience. I'm sorry for that. Actually, yes. If it is obstructing, you cannot approach the lower.
If it is obstructing, then it is a
can remove
Yes.
then and there.
Enucleate and
There is
remove
some
it, then you
space.
can.
Yes. If there is some space, first you deliver the baby and do it.
Then we will do the myomectomy.
Yes. Okay. This is it. Now you tell me few points. Every one of you, please tell me how to reduce the rate of cesarean section.
First important thing is the
Just one
counseling of
point
the patient. First is the counseling of the patient. You have to support during the time of delivery.
Okay.
And your attendants also support to us for the delivery process. Because nowadays attendants are also not supporting when the patient will go in the active labor. Kuch hona nahi chahiye, nothing will happen to baby and mother. So because we are doing in the private setup, so it's very difficult.
Okay.
And monitoring the patient is important.
Okay.
And first distress, obstetrician distress, we have to reduce.
Ma'am, obstetrician distress.
VIP cases will think early, will decide early decisions.
So reduce rate of cesarean section. The counseling has to start in the antenatal period. Proper exercises,
that is the
all
point.
the every
Yeah.
pelvic floor exercises to make her strong.
Done.
And then
Intrapartum thing. It's a prepartum.
primary 37 weeks cephalic presentation in labor should be given maximum trial, because that is the situation where the cesarean
And
section rate
when
can
we
be
are
reduced.
giving
You
the
say
maximum
the
trial,
primary cesarean section should be reduced.
Reduced,
Yes,
yes.
well taken.
Yes.
Because antenatal counseling is very important. And we should talk about the tocophobia. That is fear
Yeah.
of labor pain.
Fear.
That
Labor
also
pain,
should be
yes.
brought out and counseled. Sir, what is your take-home point to reduce the cesarean section? Shivkumar, sir?
And we have to give confidence that we can remove the baby within 5 minutes. That patient also.
Yes. So if there is emergency, we will definitely take over and take out
everything
the
should be ready, and maximum trial can be given for the primary.
Okay, so trial of labor is important. Yes, ma'am.
Right now, the art of breech delivery, madam.
Okay.
So one indication for cesarean section can be removed by that.
Okay.
And counsel the woman about the labor pain and alleviate her labor pain by giving good analgesia during labor and do active management of labor. That will reduce the labor. And just an abnormal trace in a fetal ultrasound, don't rush up to cesarean section. Resuscitate her with the ringer lactate and reduce some acidemia. Wait for some time, it will come down to normal.
So there is a new
Ma'am, I just want to add one point.
Yeah,
With the increasing rate of ART techniques and ART treatments, now the babies after the infertility treatment are called as precious babies. But every baby is precious for us.
Okay.
Even those patients with the infertility treatment can be taken for a normal delivery if counseled properly in the antepartum period.
Okay, right, well taken. So even the group practice is important so that everyone can get involved and reduce the cesarean section, especially primary cesarean section. Thank you so much.
Thank you, ma'am. Thank you very much.
Thank you, ma'am. Thanks a lot.
It was nice
Thank you.
having all
Thank
the
you for having
experience
us.
of the panelists. Very
Thank
nice.
you, ma'am.
Thank you. Dr. Jairani.
Thank you, Aruna ma'am, for the very informative panel, which took us through all the difficult scenarios which we would be caught unaware in the labor room, where we have to take decisions, and most of the times on table, especially in smaller units where every single doctor, maybe they may have an assistant, and most of the times it's only the nurse or the senior nurse who keeps assisting them. You quickly ran through all the difficulties, and I'm sure if one can remember this and hear your voice and the other panelists, when they are stuck with a difficult situation, I would ensure they would be out of it very easily. Thank you for the very practical session, ma'am.
Thank you, Dr. Vanita. I have a very esteemed panelist with good knowledge, good experience. So it was really short and sweet with practical points. Thank you, Dr.
I have to
Jairani.
add up to one thing, ma'am. If our
Yeah, please.
astrologers don't play spoil sport, I think cesarean rates will definitely come down.
Yes. So
I
maternal
totally agree, madam.
requests and muhurtam sections should be avoided. But it's very difficult, talking is very easy. Our MLA or some other politicians call us saying that you directly do the section. That's very difficult.
And if you have any problem failing that, everything will be pointed out to the time. I remember
exactly.
still one patient told me that she get into a labor pain, the second cesarean section, the previous cesarean. I took her, she said, if you would have taken it on the 2 days basis, I would have got a boy baby. She fixed up for a date and she went into labor. I took her out. She said, you missed the 2 days. That's why I got a girl baby again.
Dr. Bharati, hope you have finished your emergency. Sorry, I finished everything because all the panelists were really good. I made it a quick panel.
So it was very lovely.
You would like to add
Lovely,
something?
Arna.
Good night.
You had made it very
Could I
nice.
just speak for a minute?
Yes, please.
Yeah, sorry, I was late. I was held up in an emergency. I just stayed. And I just was able to hear as I was coming. Excellent panel. And as all of you rightly said, reducing the primary cesareans and keeping the astrologers out of the system is what we need. And on this point, Aruna, I spoke to the MLAs, the Health Minister of Karnataka when we came to Hassan. And I said, instead of telling gynecology obstetricians to reduce the rates of cesarean, thinking of all the astrologers and to them not to give any dates for cesarean to any person who comes to them. Because as you said, we're put under a lot of pressure because of that astrology part of it.
Dr. Bharati, you have to be a little louder,
Come closer to the mic. Come closer to the mic.
Please speak close to the mic.
Yeah. Can you hear me now?
Yeah, yes.
Yeah. Very clearly.
Sorry.
Yes.
I was on my Bluetooth and I have a lot of guests at home. Well, what I was trying to say is regarding reducing the cesarean rates, because the astrologers play a very huge role. We spoke to the Karnataka health minister and we told him to have a meeting with the astrologers rather than just calling the obstetricians and telling them to reduce the cesarean rates and auditing our cesarean rates and telling us it's very high. I said, sir, one meeting you have with all the prospective people, mothers to be and their family. Another one, I think you should have an astrologers meet in all the districts and tell them, you people should stop giving dates for cesareans. Keep yourself to the other muhurtams and not the cesarean muhurtam. And don't always just call only the obstetricians and tell them your cesarean rates are high, your cesarean rates are high. I think that's what
we had such meeting with our stakeholders also, but there was not much of the impact.
Maybe Foxy can write to the government of India and all the health department, and the directors should start talking to astrologers.
We have to educate the patient. That's all. It's a very important one. We have to educate them. That's more than sufficient.
Right. Thank you very much.
Thank you, Dr. Rajapriya. Thank you so much. Thank you all the panelists.
Thank you, madam.
Dr. Jairani Kamraj. It was excellent.
Thank you so much. Thank you so much.
Thank you so much.
Thank you, Dr. Jairani.
Yeah, thank you so much. I thank all the panelists. Yeah.
Jairani, whenever I see you, I'll imagine MGR is dancing here. You dance so well.
She danced so well, no? Yes.
You should not let out the secrets in webinars.
I'm going to be your Saroja Devi.
Yes, next time.
Definitely we will do it.
Okay. So on this opportunity, I request all our Foxians to please support Dr. Jairani, Dr. Aruna Suman, and me, Dr. Bharti Rajshekar, Dr. Kalpana, all of us. Please see people represent all of you in Foxy. We request you all to please get our votes and see that we can make
100%
sure. Thank you very much.
Thank you, Dr.
Thank you so much.
Thank you, Rajpriya. Thank you, Shivkumar sir, Dr. Jyoti, Dr. Niti, Dr. Sanjay Gupta sir, Dr. Shivkumar sir, and Dr. Uma, Dr. Vandana for all being with us. accepting our invite, Dr. Nidhi. Everybody sharing your knowledge. It was really amazing one for the practical approach. And Aruna, the best part, you brought all the knowledge from all of them with your questions, and that was really interesting. And thank you so much for joining us in midst of the Tuesday, which is Tuesday evening. And very, very thanks to Vanita for nicely moderating everything and also being an MOC to connect everyone together. Thank you, Vanita, and a very special thanks to Sahiti to join us on the Independence Day on your holiday. It is nice for you to join to support the webinar with your good platform. Thank you so much. Thank you, one and all. Sashi madam, I think if you're here, thank a very special time. She only made this initiative. Once she said we will do with Madhya Pradesh. Everyone is so interesting, and she gave everybody a lead to this webinar. And a very special thanks to Sashibala, and very special thanks to all the seniors here. Thank you so much, and also to Vidya ma'am, who accepted immediately her role for this panel too. Thank you so much. We wish you all a very happy
good night and all the best.
Good night.
Thank you,
Thank you,
Jayarani
Rani
ma'am.
ma'am. Thank you for providing us the
Thank you,
opportunity, and best
thank
of
you.
luck.